Okay, fine. So we voluntary to give us the possible, like, who can give us normally, like, the whole idea of the question. So, like, everyone should speak at least once before we end the session. Anyone?
I can do it, sir.
Okay, thank you, Tita.
So Obi is a 35-year-old woman, and then she's been told that her father is diagnosed with colon cancer,
Mhm.
and she wants to know if there are any risk factors and whether she can do anything to reduce the risk of developing the colorectal cancer in the future.
So, what do you
So
think?
I think yes, there's some risk factors that are there.
Mhm.
So first, I think her lifestyle. So, because she's both smoking and drinking, but she smokes half a packet a day, and she smokes. Sorry, because they say obese. She smokes a half a packet of cigarette a day, and then
Mhm.
also her weight, because she's obese, and
Okay.
then since it's her father has it, it can also be hereditary, and then
Okay.
yeah.
So that is good. So you have already told her her risk factor because she has first degree relative family history of colon cancer and obesity and smoking, which are the possible risk factor for her patient. So what do you advise for her? So she also like to know whether there is anything she can do to reduce her risk of developing colorectal cancer in the future.
I'd ask her to stop smoking.
Mm-hmm.
Maybe work on her weight so she can get into normal weight, and
Okay.
then maybe include high fiber meals when
Okay.
in yeah do when she's eating.
Yes, of course. Or what about the screening? You want to advise her to screen at what age?
Or I'd advise her to screen maybe when she's 40 years.
Yes. What? Okay, fine. Why
Yeah.
40 years?
Because she has a first degree relatives.
Yes. Remember in colorectal cancer, if they do have like first family history, that is high risk, screening should start at the age of 40 years. But the rest of the population, screening should start after 50 years. Usually it should be advised to start at 50 years. So for this patient, as Titania said, those are the possible risk factor. So the lifestyle the patient is advisable is maybe she's supposed to take a daily take of milk, vegetable, fruits. Those are actually they are very high in calcium level, and they do have antioxidant activities, so that they can actually treat her from they can prevent her from getting colorectal cancer. Then stop smoking. That is very important. As she stops smoking, she's actually reducing her risk of getting colorectal cancer. Then read for 1 minute this question, and someone will give us the justification. So I think this one, there is no need of spending time because she would like to know whether there is a way of screening for colorectal cancer. If there is, does this method detect cancer early? Then her father had a colon cancer diagnosis, therefore, Obi wonders when she would get screened for colorectal cancer. So the first question is there a screening methods? What are the screening methods? So secondly, what age? For age, you have already mentioned because she has a first degree relative, so she's supposed to start screening at the age of 40. Now, at the moment, she is 35 years old, so at the age of 40, she's supposed to start screening. So, is there any method that can detect colorectal cancer early? Anita.
Yes, there is.
What are those methods?
You would do CEA and CA19. Those are the two most effective methods.
So that means we do a tumor marker test. Any
Yes.
other screening modalities?
There would also be, okay, but these ones don't tell early, just the annual fecal occult blood testing. Yeah.
Yes, it can also work because the patient is actually have a risk of getting colorectal cancer. Okay, good. I think this one, as she has already said, we can use tumor markers. So we can use even digital rectal examination. That is the most common. Endoscopy and CT colonography can also be considered. So by this, I have already said while we were discussing, this type of cancer is the one that can be like treated or can be cured if it is detected in the early stage. Now, it seems like the slide is really very congested, but it is the cases are very simple. Can you read like for 2 minutes? 2 minutes. Okay, now Based on, so who can give us normally the briefing of the case studies first? So can you give us a summary of the history of the patient? Someone maybe who is ready to give us?
I can do it, sir.
Okay, please, thank you.
So we've been told that BR is a 66-year-old 66-year-old man who had no health issues until he just went for a general checkup, and because he had some GI symptoms like cramping and all, and sometimes he complained of having blood in his stools. Apart from that, he said he had no other problems in his health. And the stool, he said it can be because of hemorrhoids. His family, his history is notable for a paternal uncle with gastric cancer, and he said that he sometimes takes alcohol, but he has never smoked before. But other physical examination does not show any abnormalities.
Okay, good. Okay, fine. I think that is the summary in brief. Thank you. Okay, then, okay, have you seen normally the derangement in the lab parameters? What is the derangement in the lab parameters? So when you look at the BP, it seems like no, there is no much. When you look at the heart rate, so which parameter is deranged from here? Any trial, please?
The hemoglobin is low.
Okay, yes, there is a possibility. The hemoglobin level is actually very low, so the patient is actually having anemia. Okay, good. So do you think it is related to the colorectal cancer? Do you think it can be related to colorectal cancer?
Yes, it could be related to colorectal cancer.
Why?
It could be related because he passes blood in his stool. So
Okay, yes. Yes, because rectal bleeding is actually very common in case of colorectal cancer. That is why the patient is having anemia. So is there any parameter that is deranged? Any other parameter which is deranged?
Lactate dehydrogenase.
Lactate dehydrogenase, yes. But do you think it will be elevated in colorectal cancer?
Usually elevated in severe disease form. So
Yes, yeah. In fact, it can also be elevated even in colorectal cancer. Yeah, so that is one indicator. But what other parameters? The other parameters are normal, by the way, except the anemia. Albumin level is even normal. No, albumin, is it normal? The albumin level, is it normal? So what do you think? Is albumin level normal?
Yes, I think it's normal. It's within
Okay.
the range.
What is the normal levels of albumin?
3 to
3
5.
point.
Okay, yes. By the maximum is up to 5. So it is within the normal reference range. So the only derangement is only the lactate dehydrogenase and the anemia. Okay, which can be occur in colorectal cancer. So what are the symptoms that can be associated with colorectal cancer from this patient? Which symptoms are actually associated with colorectal cancer for this patient?
Abdominal cramping.
Yes, abdominal cramping, change in the bowel habit, and bleeding in the stool. Those are very important, risk factor for colorectal cancer for this patient. Okay, then BR did have colon or rectal cancer. Could it be diagnosed with CE alone? Is this
No,
patient has? Why?
CEA alone is not
Okay.
definitive,
Uh-huh.
because
Diagnosis.
you can also have elevated CEA levels in people who have inflammatory diseases or like in smokers.
Yes, it can be actually even elevated even in other type of cancers. Huh? So this condition alone cannot be, by the way, any cancer cannot be diagnosed with a tumor marker alone, because most tumor markers are not very specific. Huh? Okay, good. But remember, at the stage of the disease advanced, by the way, the CA level is usually elevated very significantly. Like the concentration will be very high at the stage of the disease progresses. So this is something to note with carcinoembryonic antigen. Okay, then now this one is related to the treatment. So read for one, I think 1 minute is sufficient. Okay, fine. So based on your observation, do you think after surgical resection, the patient is benefited from adjuvant chemotherapy? So based on the colonoscopy, the patient was found to have differentiated adenocarcinoma of the colon with 8 centimeter with significant involvement of the regional lymph nodes. So, and there is no evidence of metastasis. So what is the most likely stage of the cancer for this patient?
Stage 3.
Stage
Yeah.
3.
Yeah, stage 3, yeah, because there is significant involvement of the regional lymph nodes. Okay, true. And there is no evidence of metastasis. So you have seen normally the CA level is baseline CA is 8 nanogram, which is elevated. Then they do surgery. Yeah, they do surgery. Okay. Then do you think what is the treatment approach for stage 3 colon cancer?
You start with surgical resection, then carry out adjuvant chemotherapy.
Yeah, so adjuvant chemotherapy. So they did the surgery part, then the remaining is actually adjuvant chemotherapy. So this patient is there is the benefit of adjuvant chemotherapy. Why? Would BR benefited from adjuvant chemotherapy?
Does it prevent recurrence?
Yes, it prevents normally recurrence. So after surgery, because of the possibility of having a minimal residual cancer cell, the patient is supposed to undergo adjuvant chemotherapy. I hope you recall about which adjuvant chemotherapy will be the best chance to avoid future recurrence for this patient. Okay, which one is the best? Yeah, FOLFOX4, yes. Huh? Okay, FOLFOX4 is actually the best chemotherapeutic regimen for this patient. Okay, yeah, I think you have done the correctly. Then the next question is, yeah, by the remember the adjuvant chemotherapy usually started 4 to 6 weeks after surgery. Then a total of 6 months duration should be recommended. Okay, now can you read for 1 minute? Just for 1 minute, because I do have detailed cases for AML. So what potential adverse effect should be away from this regimen? Remember, the patient is supposed to take a modified, he was scheduled to take modified FOLFOX regimen in adjuvant setting. So what potential adverse effects should BR be aware before receiving this regimen? Talat, can you try?
Yes, sir. I think they should be made aware first of the myelosuppression due to the drugs that are being given, which all cause myelosuppression, as well as alopecia.
Okay.
And the nausea, diarrhea, and mucositis, oral mucositis.
Yes. Any other?
Peripheral neuropathy.
Yes, peripheral neuropathy associated with oxaliplatin. So you have already mentioned the major. Some of them are actually even dose limiting side effects. So what about the possibility of any other side effects like diarrhea, mucositis? Myelosuppression he has already said. Is there any possibility of diarrhea?
No, that comes with irinotecan.
Okay.
Not the FOLFOX regimen.
Okay. Any other?
Sir, I'm not really sure about the diarrhea. I know, like what has been said, irinotecan is the one most likely to cause diarrhea, but I was just wondering if you could explain. I think I know somebody who was being treated using this regimen,
Uh-huh.
and it really caused a lot of abdominal discomfort and diarrhea, especially immediately after eating.
Uh-huh.
So I was wondering, was that because of the Folfox? Well, he was not on Folfox, he was on Capox, but I
Okay.
think they're just similar. But was that related to the regimen, or was that because of surgery? Because first he had surgery.
Okay. Yeah, it is true, but surgery is most likely causing vomiting. Yeah? But also, you remember about the dose-limiting toxicity of the 5-FU. 5-FU has two dose-limiting toxicity based on the administration, like the infusion, yes, and the bolus administration. So because of the combination of bolus and infusion administration, there is also a possibility of diarrhea, even with 5-FU, yes. So most likely, there is a possibility, yeah? There is a possibility is actually because majority of antimetabolites are mainly affecting the gastrointestinal tract, which is highly proliferative in nature. Because of that reason, GI side effect is really very common. So for that patient, it is most likely associated with the chemotherapy, but mainly capecitabine. Yes, that is the most likely agent that causes GI side effects.
Okay, thank you.
Okay, good. So you have mentioned, this patient is supposed to be aware about the possibility of toxicities associated with neutropenia, mucositis, yes, and also continuous administration of the 5-FU can cause even hand-foot syndrome and even diarrhea, yes. But the bolus administration can cause diarrhea and mucositis that is commonly associated with 5-FU. So we need to give proper information about the possibility of the side effects. Then, is there any preventive approaches? This one is based on the presentation. For a patient who is having mucositis, maybe you need to consider the most topical moisturizers that are very important. Yes. So ice therapy, cryotherapy before the chemo regimen. Okay, Joyce, question?
Yeah, I wanted to ask you, supposing you have a patient who is in stage 4 or maybe late stage 3, and then would you even suggest chemotherapy to them? Because as you look at these drugs, they have really bad side effects. And having oral mucositis, the GI discomfort and the diarrhea, and that person is already in stage 4. So would you be putting the life at risk? Or
yes, but by the good question. By the before you initiate chemotherapy, the first thing is actually you need to assess whether the patient can tolerate chemo or not. That was the first decision that should be come in mind of the oncologist. Otherwise, they are actually even at risk. So especially if they are students like residents, and if they initiate without consultation of the senior, they're actually in trouble. So the first thing is you assess whether the patient can tolerate or every parameter. You look at any other comorbidities, you look at normally the severity of the condition, and after that, you make decision whether chemo will be beneficial for this patient or you have to wait until the patient condition can be actually relatively optimized. So that is the first decision. Otherwise, that is why all advanced stage of cancer might not qualified to be eligible to take chemotherapeutic agents, because even the chemo can kill themselves. That can kill even the patient. So because of this reason, if the patient condition is really very deteriorated, you have to even balance risk-benefit analysis, and you have to stay before you initiate even chemotherapy. So it is just so performance. There is a criteria known as ECOG, the European Cooperative Oncology Group performance status that should be done before you initiate chemotherapy. Yeah, that is true. So if the patient condition is very advanced and very deteriorated, maybe the patient might not be eligible to chemo because the patient cannot tolerate to chemo. So it is just depending on the patient condition. Okay, then remember you have to look at severe neutropenia. In that condition, maybe you need to delay even the chemotherapy. For severe mucositis, you need to give pain medication, local anesthetics, and other supportive care can be considered as the preventive approaches. Those are the conditions. Then avoidance of cold objectives should be recommended because of peripheral neuropathy associated with oxaliplatin, which is very common in majority of the patient population. So the recommendation is they use gloves, socks. Yeah, can be recommended, especially if the weather condition is very cold. Yes, those are the prevention modalities that can be recommended for this patient. Then, even this question is very straightforward. I just want to give you only 1 minute to answer. Just 1 minute. So the patient is complaining. Remember, after 8 cycles of chemotherapy, the patient is complaining constant numbness and tingling sensation on his left foot. So which drug is most likely responsible from this regimen? I think everyone will answer this one. Oxaliplatin, true. So Diana, so what intervention or what course of action can you take?
I think dose reduction.
Dose reduction can work.
The drug. I don't know, maybe even changing the drug, replacing the drug with another drug. Can that work?
Yeah, but mostly not recommended. You know, when we're discussing, we just normally like discuss what are the best possible strategies. And FOLFOX is like the gold standard regimen in colorectal cancer. So like the second line options we're having might not, we can check oxaliplatin with irinotecan. Yeah, that is true. But that is not, this is not the case for this condition. Okay, yes, but this is one option anyways. Any other course of action?
You can give drugs like gabapentin for treatment of the peripheral neuropathy.
Exactly, yes. So we are going, by the way, the treatment modalities are similar to like that of any other peripheral neuropathy, such as diabetic neuropathy. So like for, like, because this is a neuropathic pain, maybe we need to consider even the use of tricyclic antidepressants. That is very important. And gabapentin, yes, pregabalin can also be considered. But the pregabalin, the tricyclic antidepressants, and the gabapentin should be given at night time because of their drowsiness side effect. So this one, when you look at the course of action, the patient is actually completed its course of chemotherapy. So that means this is just a cumulative toxicity associated with oxaliplatin. So dose reduction can work best, but of course, if the condition is very disturbing to the patient, maybe we can consider any other drugs for neuropathic pain, such as antidepressants, amitriptyline, also anticonvulsant gabapentin. Okay, good. And then, after completion of this treatment, how often and for how long should BR be monitored for recurrence of his disease? In fact, most of you answered this question. How often should we monitor for the possibility of recurrence? or maybe Anjoy. So remember, you need to talk at least once before you leave. I'm just speaking, the one who didn't say anything. So Anjoy. Okay, Esther.
You're going to monitor him for about 2 to 3 years after the completion of his treatment. I mean, within, after completion of treatment, because within that duration is where there's the highest rate of recurrence.
Yes, good. The highest rate of recurrence after giving the standard treatment for colorectal cancer is within the 5 years, but it is very high, especially within the first 2 to 3 years. So that is why every 6 months we need to monitor greatly. Yes, like close monitoring is very, very important. Yes. Okay, good. You have already said properly. Then now, yes. Okay.
I have a question.
Okay.
For the peripheral neuropathy,
Okay.
why can't we give supplementation?
So supplementation, this is like the prevention.
Yes, to prevent it from happening.
Yeah, because most patients, not all patients develop by their peripheral neuropathy. That is why for this condition, we normally treat when the patient is actually presenting with the complaint. Yeah. Otherwise, you don't give. You remember about the risk of even amitriptyline, and even you give gabapentin, they cannot even sleep properly. I don't know whether you counter even these drugs. Some people even they don't function properly during the daytime. You give them even gabapentin at night time. So because of this reason, you don't really give preventive approach unless maybe avoid cold exposure, avoid cold drinking for peripheral neuropathy. Pharmacological prevention agents are not recommended. Yeah, unless the patient is complaining with these side effects. Did I answer your question, Sandra?
What about with vitamin B?
Vitamin B6 will not prevent peripheral neuropathy for this condition because the peripheral neuropathy is not associated with deficiency of vitamin B6. Remember, vitamin B6 is only prevented peripheral neuropathy that is induced by isoniazid because the principal mechanism of action is actually depletion of vitamin B6 in the serum. That is why NH causes deficiency. NS causes peripheral neuropathy. So for this one, it's just like damage. Yes, it is damage. So because of the difference in the mechanism of action, that is why we are not even using. Do you know by the NH-induced peripheral neuropathy cannot be resolved by gabapentin or amitriptyline because the mechanism is actually different. So the best treatment to prevent these peripheral neuropathies by the use of pyridoxine, not gabapentin or amitriptyline. That is why you don't see those regimens when a patient is actually having this peripheral neuropathy.
Okay, thank you.
Okay, good observation. Huh? Then now you can read this for maybe for 1 minute because they do have like 2 slides for the question. So you read for 1 minute this one. Okay, so from this case studies, what was the derangement? So this patient has been treated with adjuvant chemotherapy before. So what was the derangement for this patient? Then Patel, can you try? Okay, Phase Macau. Edith Phase Macau or okay, Macau, sorry. I think it is not Phase.
Yes.
Okay, what was the derangement?
Metastasis
Okay, to where?
to the liver, the left
Uh,
lung, and
oh,
liver and the
oh,
left.
yes, so there is metastasis to the lung and to the liver. So the patient, what is the stage of the disease?
Stage 4.
Stage 4, yes, because of metastasis. Okay, good. Any other derangement? Have you noted, what do you see about the lab parameters? Are they within the normal range? So is there any derangement in the lab parameters?
Yes.
So which derangement did you notice?
Maybe there's abnormal values of the liver function tests.
So which the liver function test is abnormal?
I think it's alkaline phosphatase, though I'm not so sure.
Okay. Oh, okay. But even alkaline phosphatase by the normal range is between 45, 44. Yeah. From my reference, it is 147. Yes, it can go up to this point, so there is no derangement in the alkaline phosphatase level. Is there any other derangement? So WBC, it is normal, yes? Hemoglobin, it is normal. Platelet count, it is normal. The serum creatinine level is still normal. Blood urea nitrogen can go up to 20. ALT and ACT by the it can go up to 50. Yeah, I usually recall by yes. As long as it is below 50, you can say ALT and ACTs are actually normal. Then even bilirubin level, I don't think so. It is very high. Then you can see the CA concentration was 22 nanogram. This is the only derangement lab parameter I observed from this patient. And so what is the role of chemotherapy now for this patient? What is the role of chemotherapy for this patient?
Palliative?
Yeah, yes, palliative care. That is the only role. So the only goal of therapy, even for this stage, is just to prolong the survival of the patient because we cannot cure the condition. Now we have finished about colorectal cancer, and I do have for the next 1 hour we are going to discuss about a case study of AML. So you can read for 2 minutes. Yes. Then at the end, you'll tell me what are the signs and features exhibited and what is the relevant history of the patient, which is consistent with the diagnosis of acute myeloid leukemia. I gave you like 2 minutes to go through it. So, have you seen any sign and features that is consistent with ML for this patient? And what is the derangement for this patient first?
You can tell that his white blood cell count was too high.
Yes, too high is good. Huh?
The lab results show that the blast was 60%, which is too high for the blast percentage in the bone marrow.
Okay, yes. Even also, there is also blast cell in the peripheral blood, which is more than 90%. Huh? Okay, good. In the bone marrow, there is 60% blast cell. Good. Any other?
The patient has low platelet count.
The platelet count is actually very low. Okay, good. Which is 46. But were there any sign of bleeding from the patient? Not really, yes. There is no any sign of bleeding from the patient. Okay. Okay, so any other derangement?
Potassium and phosphorus levels elevated.
The potassium level, this one, is it elevated? This is low, by the way, yeah? This potassium level is very low.
So his hemoglobin levels are low. Could that not be due to bleeding?
Yes, it can be due to bleeding, but it can be also because of bone marrow suppression. Yeah, it can be either. Yes. Okay, then the phosphorus level is high. What is the normal phosphorus level?
(2.5 to 4.5).
Yes, okay. It is just up to 3.4 up to 4.5. Okay, in milligram per deciliter. So you can see the phosphate level is slightly elevated. And what about LDH level? Is it normal or high?
High.
Okay,
High.
it is high. Yeah, it is high. Then you have seen the patient is actually having oral candidiasis as well.
Yes.
So what is the cause of oral candidiasis for this patient?
Infection because
Neutropenia.
Neutropenia, because the immune system is actually declined. Remember, candida is actually very common when the immune system is actually compromised, or when we use any condition that actually kills the normal flora within the oral cavity. Maybe use of steroid can also cause increase the risk of candidiasis because the steroid can actually kill, can actually suppress the immune system. Okay, good. So, in short, which sign and symptoms are consistent with AML for this patient? Just tell me one by one. Which sign and symptoms are consistent for this patient? So start from the top. The WBC count is high, yes? Okay,
fatigue and
yes,
fever.
start with fatigue and fever. Okay, good.
Yeah. Then you go to the blood cell counts.
Yes, the WBC count is really very high. What is the risk of by the high blood cell count?
To this exempt items. It just happens actually here that the 960 on the sales, okay, actually balances out our input tax entirely.
So any other person? Patil, are you back? Okay, Faria?
Yes.
So what do you think, Faria? What are the possible signs and symptoms of the patient is having, which is consistent with ML?
Fatigue.
Okay. Don't repeat what has been said. Fatigue and fever, it has already said. Fatigue and fever, it has already said.
Also, the inability to eat.
Okay, it could be inability to eat. Any other?
Oral candidiasis.
Oral candidiasis, yes, this is an infection.
Poor dentition.
Of the blast.
Sorry?
Poor dentition.
Okay, because when you are talking together by the, it is very hard to hear, especially with Zoom. Okay, but to start from the top, as I said, the WBC count is very high. Then the blast cell, the leukemic blast space is like 90%. Then hemoglobin level is low. Yes, the patient is having anemia. Platelet count is very low. Yes, BMA assay revealed that there is 60% blast cell. And also, the patient is positive for myeloperoxidase. Do you remember this one? Myeloperoxidase is an enzyme that is enzymatic test that will tell you whether there is a myeloblast or not. So the patient is positive for myeloperoxidase means there is myeloblast. So the myeloid lineage is really affected, not the lymphoid lineage. So which is very consistent with the diagnosis of AML. And apart from that, these CD markers are very common in myeloid leukemias. When myeloid lineage is affected, CD30 and CD30s are usually positive. Then all serum chemistry is normal, except the potassium and the phosphate level. But I was wondering what causes low potassium level for this patient? Is there any reason that causes low potassium level? Is there any reason that causes low potassium level? Any trial? James, what do you think?
I'm not certain.
Oh, okay. So James said, I'm not sure. Then who is talking next? You can continue.
The fact that he has poor appetite. Yeah.
Yeah, exactly. So the only relevant information that can be linked with a low potassium level from this patient is normally poor appetite. He was not taking properly, so most likely he was not getting like a dietary source of potassium. That is the only explanation. Do you have maybe any other different opinion? This was like my observation.
Yes, I have a different opinion.
Okay, so tell us.
Okay, when I remember you taught us lung cancer, there was a paraneoplastic syndrome.
Okay.
So I feel like what's also happening here could be a paraneoplastic syndrome as well.
That is affecting that paraneoplastic syndrome in case of lung CA is very common. Like inappropriate secretion of SIADH is very common. So you are saying there is a paraneoplastic syndrome that affects the potassium level.
Yeah, that's what I think.
Okay. Okay. Oh. But me, I don't think so. Yeah, because when I look at AML, yeah, the problem is mainly in the bone marrow. In fact, if it affected the kidney, we expect even like high level of potassium instead of having low potassium. So then even when you look at AML, it is just acute myeloid leukemia, and the turnover of the cell is very high. We expect even the possibility of tumor lysis syndrome. So most likely we are expecting hyperkalemia instead of hypokalemia. So most likely the cause of hypokalemia for this patient is related to diet. I think that is normally my observation. Yeah, otherwise the other condition is very unlikely. Yes, because okay, huh?
I actually agree with Esther because there's the document saying that even though the mechanism for hypokalemia is not clear, there is the paraneoplastic syndrome that affects the RAS system, which leads to diuresis a lot. So potassium is lost in that way.
Oh, in case of ML?
Yes.
Okay, maybe there is something which I don't know. So that means there is a possibility of actually paraneoplastic syndrome in case of a male that causes loss of potassium.
Yes.
Okay. Oh, that one I don't know. But remember also the possibility of diet. Low potassium can happen even when the patient is actually having a poor appetite. Okay, it might be if you have the evidence. Okay, good. Now, those are the parameters that are consistent. Then, by the way, I didn't really go through you about the type of ML. There are actually different types of ML. So this is the French, American, British classification. M2 means there is actually elevation of premature monocytes. So this is a kind of ML that is involved with like elevation in the monocyte count. Because I feel like the information is like too much for undergraduate level. So that is why I didn't go through about the classification of ML. So FAB M2 means there is an indicator of myeloid with maturation. So this is just like a monocytic type of ML. Okay, fine. You have already said all the information or the relevant information. Also, please note that cells of myeloid origin commonly contain myeloperoxidase enzyme and expresses surface marker like CD13, 33, CD14, CD15. Those are the most common CD marker when a patient is actually having AML. Even those are some of the parameters they are going to use to differentiate whether the patient is having AML or ALL. Okay, good. So what's the goal of treatment and what type of treatment can be given for this patient? So what is the goal? Now we do have the information. The patient is having consistent diagnosis of AML, yeah, because of the features and even the lab parameters. So what is the goal of treatment?
To induce remission.
Yeah, yes, induce remission. Welcome, Gitonga. Huh? That is the primary goals of AML, especially in the goals of treatment, the initial goals of treatment. So what are the types of treatment? What are the phases of treatment in AML?
Induction and post-remission.
Yeah, induction and post-remission. Yeah. Okay, so what type of induction treatment can we give for this patient? So what kind of induction therapy can we give for this patient?
A combination of an anthracycline plus an antimetabolite like doxorubicin or daunorubicin plus cytarabine.
Okay, good. Those are the gold standard induction therapies in case of a male. Whether you see any guideline, normally those are the standard when a patient is actually having a male. So the goal is to clear the bone marrow and peripheral blood of all the blast cell with the hope of normal blood cell component to regenerate. So that is the goals of therapy by day for induction. And mostly the standard chemotherapy regimen for induction for AML is anthracycline in combination with cytarabine. I hope you remember about the 7-3 protocol. Yes. So when you combine Anthracycline with cytarabine, it is one of the most effective chemotherapy regimens used to treat adult AML, and the possibility of complete remission rate is between 60 to 80%. Yes, but remember, the 7-1 is an indicator of the duration of treatment of cytarabine, and based on evidence-based medicine, continuous infusion of cytarabines are preferred because the regimen produces high response rate as compared to the bolus injection during the induction phase of treatment. That is why continuous intravenous infusions of cytarabines are usually recommended instead of giving the bolus injection. So this is just based on the comparative studies. So when you give continuous infusion for 7 days, you can achieve possibility of complete remission. So within a single cycle or one cycle of 7+3 protocol, we can achieve 60 to 80% remission. Okay, good. Then you can see for 1 minute, this is still the continuation of the case study. Then you can see, read for 1 minute. So what is your observation? Now I am back. Huh? So what you observe, 24 hours after GV's induction chemotherapy was initiated, the following lab values were obtained. Like after 24 hours, they have done all those parameters. So you have seen a dramatic change of the lab parameters from the baseline. So what causes normally like the change of these lab parameters suddenly? WBC count reduced, yes? Potassium level elevated. Phosphorus level, in fact, initially it was even high. Uric acid level is high. The calcium level is low, and the creatinine level is high. So why have this lab parameter changed so suddenly? Okay, so what do you think? Any trial? Okay, immaculate?
Sir, I'm not sure.
But what do you think?
Well, obviously, it has something to do with the regimen that we give the patient.
Okay,
but
yes.
I can't justify.
Okay. Kibira, Mutoni Kibira?
I'm not sure.
Okay, is there any other? What is your observation by the way? Okay, any other?
Sir,
Uh-huh.
I think since this patient had like a really high number of blast cells, if there's induction of chemotherapy, there are high chances of those cells busting or lysing, and whatever content they have might be toxic in one way or another.
Yeah, that is true. So remember, in high-grade tumors, such as like aggressive lymphomas, the Burkitt's lymphomas, what we have discussed previously, and even in acute leukemias, the cell turnover is actually very high because they are responsive to chemotherapy. There is significant destruction as soon as possible after inductions of chemotherapy. So this sudden change of the level of electrolyte is actually because of tumor lysis syndrome, so TLS. So when you look at the potassium level, by the way, I got one evidence from one journal. I got normally one reason from the journals. What Esther and Faith said is correct. There is a possibility of actually having hypokalemia in ML patient. It says hypokalemia, the loss of potassium in case of ML, the mechanism is not really known, but there is a possibility of actually paraneoplastic syndrome. That means the tumor can produce a significant increase in the renin-like activities because of the blast cell. So this renin-like activities enhancement can actually activate the renin-angiotensin aldosterone system. So if aldosterone system is actually very high, means it can actually retain sodium and water, and it can actually excrete potassium. So they are saying that this is the possible mechanism of potassium loss in ML patients. I think the evidence is really very convincing. You can actually even read. It was then in the early 90s. It was then normally in the early 90s. This is just a case report. Paraneoplastic hypokalemia in acute ML patients, a case of renin activity in ML blast cell. So there is a possibility of renin activities that can actually cause loss of potassium. But when you look at after inductions of chemotherapy, the potassium level is dramatically changed. So this dramatic change of potassium is actually because of tumor lysis syndrome. Remember, in case of tumor lysis syndrome, there is a change in the electrolytes in the potassium, uric acid level, calcium, and phosphorus. But mostly, potassium is very high, phosphorus is usually very high, calcium can be eliminated, and because of hyperphosphatemia. Remember, one of the side effects of high phosphate level is reducing the potassium count. So the calcium level can be low. So this is still the effect of TLS. Then when you look at the creatinine level, Remember, one of the complications of tumor lysis syndrome is acute renal failure. So, as a result of hyperphosphatemia and high level of uric acid, there is a possibility of actually blockage of the kidney, and the creatinine level can be elevated. So, this is as a result of TLS. So, this dramatic changes is because of the high tumor response and significant reduction in the, you can even see how the WBC count is actually dramatically reduced, and this ultimately reduces the intracellular content into the serum. Then, is it possible to prevent this condition? Is it possible to prevent or minimize the possibility of having these incidents after induction of chemotherapy? If so, how do we prevent? Is it possible to prevent? I remember during our discussion in the class, we I mentioned something about the possible prevention mechanism of tumor lysis syndrome. Any trial?
I think you can start by a low dose so that you're not killing all of them at once.
Low dose of anti-cancer medication?
Yeah, and then add dose.
Yeah, you know the problem, Immaculate, when you actually give low dose means you might not achieve even complete remission, and this condition is very aggressive and it requires aggressive treatment.
Right, okay.
Okay, so that strategy might not be possible.
Can you give mercaptopurine?
Why?
I'm not so sure, but I just remember you saying something like that.
Mercaptopurine?
Yeah.
Okay, I think, Anjo, you normally like just like misinformation. Eh?
No, because it reduces the level of uric acid.
Mercaptopurine is does not reduce the level of uric acid. Let me correct you before I go to the next. Before I go to the answer, mercaptopurine undergo metabolism by xanthine oxidase enzyme. So if you give them allopurinol, if you give them normally allopurinol with mercaptopurine, you need to reduce the dose at least by 25% so that you minimize the possibility of adverse effect. That means they do allopurinol is actually xanthine oxidase enzyme inhibitor. Mercaptopurine undergo inactivation or metabolism by xanthine oxidase enzyme. So if you give them two drugs at the same time means you're actually increase the risk of side effect of mercaptopurine because of reduction in the elimination. This is what I said in the class.
Okay.
Now, did you recall that?
Yes.
Okay, fine. But you can say allopurinol can be given for this patient, so to prevent what? Hyperuricemia. So one strategy for prevention of TLS is give prophylaxis of what do you call prophylaxis allopurinol, mostly between 300 to 600 milligram dose per day. But mostly we give them in divided dose, and the strength we're having is 100. So you give them in divided dose 100 milligram 3 times daily. Yeah, like before chemotherapy, 24 hours before chemotherapy is one strategy that prevents even the possibility of acute renal failure as a result of hyperuricemia. Okay, then, is there any strategies, any other strategies that can prevent TLS? Any strategies? I mentioned one strategy, give prophylaxis of allopurinol for high-grade tumor, but then, especially in AML, usually they are supposed to consider. Any other? What about hydration?
Yeah, you can hydrate with saline, normal saline.
With normal saline, like 24 hours before chemotherapy and even after chemotherapy, it is actually mandatory.
Yes.
Yes, so pre-hydration is, so those two strategies are actually the most common strategies that can be considered in the prevention of tumor lysis syndrome. But if it happens, how do we manage those metabolic disturbances? If it happens, how do we manage these metabolic disturbances?
I want to try. Can you give potassium supplements?
No, hyperkalemia. You know, for this patient, you don't really give a potassium supplement because the potassium level is commonly high. It's mostly high in case of TLAs.
We can give mannitol.
Okay, why mannitol?
So that we reduce hyperkalemia by increasing urine output.
Okay. Any other option? Because hydration can work best instead of actually even giving mannitol. Yes, but why don't you think about the management of hyperkalemia?
Yeah, you can also.
Okay, continue, please.
Sir, how about giving potassium binders?
Yeah, potassium binders, but mostly for initial stage normal shifting potassium with insulin is commonly recommended. Insulin with dextrose. Don't forget the combination of insulin with dextrose because of the possibility of hypoglycemia. Mostly we combine insulin with dextrose is usually given. So by the way, when you look at electrolyte disturbances in tumor lysis syndrome, you have to manage accordingly. Look at the disturbances and you manage the specific treatment modalities. For example, if hyperkalemia, you give them maybe you give them insulin subcutaneously, then along with dextrose, so that you can actually reduce the at least you shift. After that, maybe you consider a potassium binder. Then, if the phosphate level is very high, you can actually give phosphate binders. Do you remember about the phosphate binders? What we have covered in the last year in this semester when we were discussing about chronic kidney failure? You remember the phosphate binders?
Yes.
Tell me, please.
For example, calcium carbonate.
Yeah, the calcium-based phosphate binders we do have. Calcium carbonate is in fact the most commonly used phosphate binders. Okay, any other? In fact, the calcium level is actually very low. So the best option is to consider calcium-based phosphate binders will work best for this patient. But do we have any other phosphate binders apart from calcium carbonate? You don't remember Sevilama?
Sevilama.
Yes, those are,
Yeah, I remember Sevilama specifically.
Yes, this is normally the non-aluminum, non-calcium phosphate binders that can be commonly employed in the management of hyperphosphatemia. Then what about for the high level of uric acid?
Allopurinol.
Yes, allopurinol normally used to prevent, like it usually, by the way, I will discuss when we're in the last sessions of this course, we're going to discuss about oncologic emergencies associated with the treatment or the cancer condition, and one condition is tumor lysis syndrome. Then hyperuricemia is very common, electrolyte disturbance in TLS. Then when the level of uric acid is very high, we can use allopurinol, but allopurinol does not prevent the already produced uric acid. In case the uric acid level is like in terms of 1,000, it can go even by the in terms of 1,000. Yes, level, what will be the best strategies instead of giving allopurinol?
RAS buricase, maybe?
Yes, because they promote what? The excretion of uric acid. So urate oxidase enzyme, urate oxidase or a class of drugs like RAS buricase can be a drug of choice, but because of availability issues by in most of our settings where they are using allopurinol. Allopurinol is the most commonly used in the prevention as well as in the treatment of hyperuricemia. Yes, so if you correct all those parameters, you will see normally an improvement in the acute renal failure. So those are the strategies for the treatment of these metabolic disturbances. Okay, can we proceed to the next case? Or do you have any question?
Yes, I have a question. So you said we give calcium-based phosphate binders.
Yes.
But since the phosphorus levels look like they're back to normal, when calcium phosphate precipitates form, then predispose the patient to kidney problems.
That is also another possibility. But remember, we normally give calcium phosphate and we monitor. Yeah, we monitor. You just give calcium carbonate and you monitor the electrolyte level. Once it backs to normal, we're going to actually stop the calcium carbonate. But there's a possibility here. The moment you give them calcium supplement, it binds with phosphate, and there is a possibility of this precipitate formation is very common. But this TLS tumor lysis syndrome usually occur like 24 hours after chemotherapy. So this is just an acute manifestation. So you treat for a few days, then when the electrolyte level is back to normal, you normally discontinue calcium carbonate. Otherwise, in the short-term treatment, the probability of calcium phosphate precipitate formation is very, very unlikely, yes. It is very unlikely to occur in a short duration of treatment. But of course, if we treat for a long period of time, there is a possibility of this precipitate formation. But of course, we need to assess the renal function test and the electrolyte level when we are giving this treatment. Did that answer your question? Esther, did I answer your question?
Yes.
Okay, good. So any other issues? Okay, fine. So the whole idea is expect the possibility of TLS when you are treating ML. Yeah, especially in case of induction. Okay, then I think we have already exhausted. So remember, TLS is very common, especially 12 to 24 hours after chemotherapy is initiated. That is why we need to be very careful. Then this TLS disturbance can cause arrhythmia as well as acute renal failure because of electrolyte disturbance. There is a possibility of arrhythmias and also acute renal failure. Then another important point, TLS is very common in high-grade tumors, such as acute leukemias and even high-grade lymphomas. Then TLS is very unlikely to occur in solid malignancies. So this is another important point to note. So it is very unlikely to see TLS in solid tumors after chemotherapy. But in hematological malignancies, we need to be very careful, and which is very, very common. Okay, then for this patient, despite the potassium level is low on admission, we need to be very careful to initiate replacement therapy. yes, is not recommended before chemotherapy in a patient whom TLS is highly likely. For example, this patient, a male, on admission, the potassium level is very low. Yes, very low, as the reason mentioned above. So before chemotherapy, we don't really initiate replacement therapy for this patient because the risk of TLS and high level of potassium is very high in this patient. So we don't need to give replacement therapy before chemotherapy in the context of this case study. Okay, now can you read the question for 1 minute? Just read for 1 minute. So what is your observation? The patient has received allopurinol therapy and aggressive hydration throughout his induction chemotherapy. The metabolic abnormalities gradually resolved as his WBC count declined and tumor lysis diminished. What other complication may occur during induction therapy, and can they be treated? What other complication do you expect? What other complication do you expect, guys?
Infections.
Sorry?
Infections due to the low WBC count.
There is a possibility of infection.
Yes.
Okay, good. Yes, there is a possibility of infection. Yes. Any other complications?
Cardiotoxicity, depending on the dose of the anthracyclines.
Okay, but do we expect normally cardiotoxicity with this induction treatment of ML? Immaculate. I like normally your observation, but do you think how is the probability of having cardiotoxicity for this patient?
Yeah, I think if they're on the dose for too long, if, for example, we decide to give them doxorubicin along with cytarabine.
Okay, yes.
So, but this is for 3 days though.
Yeah, yes, remember we give
So he
normally
could get
only
acute cardiotoxicity. It could be acute.
Yes, okay. Because most of the time by the, I like your observation, there is a possibility by the, because some patients can be very sensitive even for a small dose of doxorubicin. But the problem, the probability of added toxicity is very unlikely because remember, this is for 3 days, and most of the time, induction of AML is just only one cycle. So the probability of reaching cumulative dose toxicity of doxorubicin is very, very unlikely. That is for 50 to 550, 50 milligram per meter square. So like the 3-day doses cannot really reach with this level, and the probability is very, very unlikely. But there is a possibility, but very unlikely. Okay. Any other toxicity? But I like your observation. Any other complication? There is a possibility. So what do you expect when you give chemotherapy? That is the question. Like
Myelosuppression, sir.
myelosuppression, yes. So there is a possibility of myelosuppression. As a result, the patient will have anemia. Then even there is a possibility of WBC count is reduced, platelet count will be reduced. So most of the time, based on the evidence, patients receiving cytarabine and daunorubicin after induction, there is a possibility of profound anemia, reduction in WBC count and thrombocytopenia after therapy. And even this condition can persist up to 21 to 28 days. So that is the possibility. So in such a scenario, the recommendation is, so it is possible to treat, that is true. Those complications can be treated. The first thing is normally we can use granulocyte colony stimulating factor can be given. But remember, GCSF can stimulate leukemia cells as well as the normal granulocyte precursors. However, several studies show that these agents, when used an adjuvant therapy for AML, they are often safe and do not adversely affect the disease outcome. You know, the problem with this class of drugs is the filgrastim, they can actually stimulate even the production of leukemic cells as well as the normal granulocyte count. That is why most commonly it should be given 24 hours after chemotherapy. You just give at least chemotherapy, then 24 hours later, you can give them. But based on several studies, normally the possibility of activating the leukemic cells are very, very minimal. So we can give at the prophylaxis, and mostly this drug is widely available in our setting. And I think the adult dose is usually 300 microgram subcutaneously, can be given during the risk period. Then remember about the possibility of serious bleeding. Yeah? Serious bleeding can actually happen, but this can be done platelet transfusion. Huh? Then, especially if the platelet count is actually less than 10,000, we can do platelet transfusion. There is actually platelet of the platelets in case of thrombocytopenia that can be considered. But the major problem is, I think getting platelet alone is really very tough. That is a major challenge I noticed in KNH, and mostly they normally do whole blood transfusion. You just do whole blood transfusion is the most common approach. Yeah? Okay, but if a patient is having only platelet problem, there is no essence of giving normally doing a whole blood transfusion. But you know, because of limitation in the setting, yeah, there is no option. Okay, fine. Then can you read this? Okay, question. I don't know. Do you have any question? Okay. So you read for 2 minutes, huh? Then we look at the question together. So what is your observation? What is your observation from the case study? Shava, can you try?
Yes, sir.
So can you try? So what did you understand from the case studies, sir? What are the major pointers?
What are the major? One second.
Sorry?
Sir, just one moment. You know, I lost power.
Oh,
so
okay.
If you saw, I don't know if you saw, I just logged back in a few moments ago.
Oh,
so
no.
I haven't really had time to read properly.
It's okay. I can go to another person, no problem.
Okay, thank
Tara.
you.
Okay, Tara.
The main pointers that we got from this case study, I think, would be probably how to effectively treat the acute leukemia, and basically just what we had learned in class. But then in terms of this, I think post-remission therapy should be carried out because it will also prevent the risk of relapse, which would be very common for this type of cancer.
Okay, good observation. Now the patient has already completed by the induction therapy, and the WBC count falls to less than 100, and his platelet count to fall 5,000, and he received transfusion for platelet every 2 to 3 days and to prevent bleeding complication. So on day 9, he developed fever, a fever of a temperature of 38.8 degrees Celsius. Then he was started immediately on empiric broad-spectrum antimicrobial therapy for fever, neutropenia, and subsequently resolved. So he developed normally neutropenia and subsequently resolved. So on day 29, his WBC count was like normal with normal differential. So the total WBC count back to normal, even all the differential. And his platelet count was also normal. Yes, on day 29 after induction, he was actually having normal WBC count. That means he was achieving like complete remission. So he received packed RBCs transfusion on 2 separate occasions when his hemoglobin fell less than 8 milligram per deciliter. Then also a repeat bone marrow aspirate showed there is no evidence of persistent leukemias. There is no blast cell in the bone marrow. That means the patient was achieving complete remission. So JV was told that his leukemia was in remission. Nevertheless, his hematologist recommended additional chemotherapy. And JV's question why this is necessary if I achieved, if he was achieved complete remission. So is post-remission therapy necessary? And if so, what therapeutic options are available? So remember, the possibility of relapse is very high in case of ML. That is why after inductions, after 1 or 2 cycles of induction, chemotherapy is given. The patient is supposed to be given post-remission. We call it consolidation therapy so that it can kill the remaining residual cells. Cancer cells. So what are the therapeutic options are available to be given at the post? We have agreed post-remission therapy is important. Then if so, what therapeutic options are available to JV? So what treatment modalities can we give in post-remission therapy? Victor?
You can offer him maybe either high doses or maybe like a bone marrow transplantation.
Okay, good, yes. So mostly we can use either a stem cell transplantation or high dose of chemotherapy. If you remember, we have said in our setting, because high bone marrow transplantation is not possible, and most of the time the patient is treated with a high dose cytarabine. So cytarabine is the frontline drug in the management of post-remission. So generally, although 60% of the patients treated with ML achieved complete remission after induction, the median duration of remission is only 12 to 18 months. They can be cancer-free for 12 to 18 months, but the problem is there is a possibility of relapse after this period. They can be like remitted within this period, but there is a possibility of relapse. So in conclusion, there is a need of consolidation therapy so that we can give the best chance of survival. So for this one, post-remission therapy usually includes HiDAC. HiDAC means it is just abbreviation of high dose of cytarabine or high dose of cytosine arabinoside alone is commonly recommended. Okay, good. Now, another question. Can you read this question maybe for 1 minute? Read for 1 minute. We're almost about to close the session, and I hope you are not getting bored. Read for 1 minute. Okay, so what is your observation? The patient does not require allogeneic transplantation at this time, and the hematologist recommends. But the leukemia is mainly is managed by hematologists. Yeah, those are the hemato-oncologists. So 3 courses of HiDAC was given as a post-remission therapy, but 1 week after he was declared to be in remission, JV is readmitted to the hospital to receive HiDAC of 3 grams per meter square twice per day. If you remember, normally we have mentioned HiDAC is usually given high dose. For adult, for younger patients less than 60 years old, we normally give 3 grams. Then on day 1, day 3, and day 5, yes, 3 or 4 cycles is most commonly given. So what are the potential acute and delayed toxicities associated with HiDAC, and how can these effects be prevented? So what are the toxicities of cytarabine? I think that is the whole idea of the question. What are the toxicities of cytarabine?
Nausea and vomiting.
Okay, nausea and vomiting. Any other? Any other? Any other possible toxicities with cytarabine? I think I mentioned even when we were discussing about the case studies on Friday, like I don't know how many weeks ago. I mentioned about some of the toxicities of cytarabine. Okay, huh?
What about local effects on the site of administration?
So this like local reaction at the site of administration.
Yes.
Okay. Any other? There are a few things you need to know about cytarabine. Ocular and cerebral toxicities. Especially with high dose, the possibility of cerebral toxicities can cause even ataxia, cerebral ataxia, and also even it can cause ocular damage. Yeah, I think this one we have seen even in the practice areas. Some patients normally developed some problem with this high dose of cytarabine. So it can actually produce major cerebral, ocular, and skin toxicities. So ocular toxicities results from the damage of the cornea epithelium that occurs when cytarabine penetrates the epithelium through the anterior chamber of the eye or the tear. That is the major issue. So ocular toxicity is very key. As a result, the patient can have conjunctivitis, excessive lacrimation, and even ocular pain, photophobia, and blurred vision can be occurred with high dose of cytarabine. So monitoring of the eye is very essential. By the way, did anyone came across about artificial tears? Anyone who came across with artificial tear eye drops? Anyone who came across?
Yes.
Okay, so what are the principal indication of artificial tears? What is the principal indication if you came across?
Dry eye.
Yes, when the eye dries, especially in older population, dryness of the eye is very common, by the way. Yeah? In fact, I have never seen the drops, but I have seen a prescription of artificial tears. So this conjunctivitis and any other sensation can be actually resolved with Hydac. So 2 drops every 4 to 6 hours administered concurrently with Hydac generally prevents these symptoms. But most likely, the most recommendation is corticosteroid eye drops can be used as an alternative to artificial tears if the symptoms of conjunctivitis occur. So if there is actually inflammatory reaction, such as conjunctivitis, mostly steroids are commonly given. Even for cerebral ataxia, mostly steroids are usually given to prevent these side effects. And also there is a possibility of dermatological toxicities, which manifests as a rash in most of the patients. So you will see like whole body rashes after high dose of cytarabine. So if you see a patient with cytarabine, you need to assess the possibility of cerebral toxicities and look at the possibility of ocular toxicities and look at the possibility of the skin toxicities. So those are the major points you need to note. Then would recommendation for induction and post-remission therapy differ if JV were elderly, like 60 years of age or older? Were there any dose differences? Were there any dose differences? What do you think? Okay, fine. Remember, older patients are generally, they do have less tolerance to intensive induction post-remission, and most of the time, slow doses are usually given. Like for example, for remission, so this is the dose we can give for older population, like above 60 years. But for adults like less than 60 years, usually gives 3,000 milligram per meter square twice daily, day 1, day 3, and day 5. So there is actually a difference in the doses, not in the drug. So we usually give low dose for elderly population. Okay, I think you can refer your notice on email because I have already given the dosing schedule. Okay, fine. Now, this patient has taken the 7+3 induction regimen, and look at normally what happened later. For 1 minute. So the case studies, it was telling us the patient was initially on remission because the blast cell is less than 5% in the bone marrow. So the patient achieved. However, recent CBC showed there is a significant drop of WBCs from 150 to 90 on day 30, 90,000, 10 days later. Then a subsequent bone marrow biopsy revealed that the blast cell in the bone marrow is 60%, confirming the diagnosis of relapsed ML. Now the ML is actually relapsed after induction. So what treatment options for AW at this time? So I remember I did take you through about treatment of relapsed ML, but what do you think? How do we treat relapsed ML in case if the patient is relapsed after induction? Any trial? Okay, fine. So in younger patients, failure to achieve remission or disease relapse remains the major cause of treatment failure. So the relapse treatment regimen, usually we still use cytarabine, intermediate dose cytarabine to high dose of cytarabine can be considered. Also, even a combination of fludarabine, cytarabine, and GCSF can be considered, or cytarabine and GCSF followed by allogenic stem cell transplantation can be done. So generally, we can consider transplantation we can consider even cytarabine with GCSF support can be considered in cases of relapsed AML. Okay, I think this is all I have for you today, and our focus for today is a case study of AML and colorectal cancer. So, any question?
Sir, could you
Yes.
please show us that slide? Oh, yeah, here. Explain the relapse, because
Okay.
I think when I was looking at the notes, I think I only saw induction therapy and then post remission. But in terms of relapse, sure, I saw that. Was that in the note?
No, relapse, it is not in the note. Huh? So this is not in the note. That is why I mentioned normally we have not covered about the possibility of relapse AML. But in case of relapse, those are the strategies we are going to use. And I will share this slide as well so that you can check. Huh? You can refer.
Okay, thank you.
Okay, fine. Huh? So any other issues? Did you learn something? I think that will be like the concluding remark. Huh? Did you learn something?